Patricia Pelikka is next with Dr. Alfred Buxton, Director of the Electrophysiology Laboratory at the Beth Israel Deaconess Hospital in Boston, Massachusetts, to discuss ICDs should be used more judiciously in the primary prevention population.
Perhaps we could start by talking about the guidelines, Al, for placement of ICDs for primary prevention.
Certainly. The current guidelines for utilizing defibrillators for primary prevention of sudden cardiac death are based primarily on the results of trials, randomized clinical trials, including MADE-2 and the SCUD-HEF trial. And these trials included patients, in the case of the MADE-2 trial, patients who had coronary disease and a prior myocardial infarction at least 1 month earlier, whose ejection fraction was 30% or less. And the current guidelines mirror those entry criteria for that trial. In addition, they include the criteria from the SCUD-HEF trial, which included patients whose ejection fraction was 35% or less due to coronary or non-ischemic cardiomyopathies, and functional class by New York Heart Association class 2 or 3. Now, the guidelines which grew out of the results of these trials state that if the patient has an ejection fraction of 35% or less and is New York Heart Association functional class 2 or 3, they are eligible for an implantable defibrillator. And in the case of patients with coronary disease, if the ejection fraction is 30% or less and the patient is New York Heart Association functional class 1, then the patient is an appropriate candidate for an implantable defibrillator. There are other guidelines that receive less attention but are appended to these requirements, but they're very important. And they include the fact that there was no myocardial infarction documented within the previous 40 days, as well as the fact that the patient must be estimated to have a reasonable quality of life for at least 1 year. And that excludes patients who have a number of comorbidities that are likely to limit the efficacy of the implantable defibrillator within a reasonable follow-up.
So we're really placing a huge amount of decision-making on a simple measurement of ejection fraction, which can be variable depending on the technology used to derive that.
That's correct. As any practitioner knows, the results of ejection fraction are dependent on the technique used to measure it, possibly the conditions under which the value is measured, as well as the reader who is interpreting the study. In addition, another limitation of ejection fraction is the fact that it doesn't measure directly any electrical property. And we know from numerous studies that have been conducted over the past 30 years that the vast majority of patients who experience a cardiac arrest or sudden death do so as a result of a ventricular tachyarrhythmia, either ventricular tachycardia or ventricular fibrillation. And while there's abundant data that patients whose ejection fraction is reduced are at increased risk for this, it's very difficult to quantitate this. In addition, for reasons of practical application, we tend to dichotomize ejection fraction, but ejection fraction is a continuous variable. It's a biologic variable. And starting at ejection fraction levels of 40%, we see as ejection fraction decreases that there's a continuous, almost linear increase in the risk of cardiac arrest or sudden death with reducing the ejection fraction in any individual patient.
So in the United States, what percent of eligible patients are receiving ICDs for primary prevention?
The figures I've seen suggest that about 20% of patients who meet these ejection fraction criteria are actually receiving defibrillators in practice today.
It sounds like we need better evidence to try to sort out who should receive these devices.
I think that's very, very true. The limitations, of which there are many, include the fact that patients included in the randomized trials upon which the guidelines are based were a heterogeneous group. And although they met the entry criteria of an ejection fraction, for example, in the case of MATE-2, they met the ejection fraction cutoff of 30% or less. As any practitioner knows, there are widely varying characteristics of patients whose ejection fraction may be low. And included within that group are patients who have other characteristics that suggest that they're actually at very low risk for sudden death, while there are other patients that have characteristics that place them at very high risk not only for sudden death, but also for non-sudden cardiac death. And these competing risk factors for mortality from non-arrhythmic means greatly limit the efficacy of the defibrillator and the ability of the defibrillator to reduce mortality in those patients.
So if clinicians are only implanting ICDs in about 20% of the eligible patients, do you think they're using the right criteria to decide on who gets these?
I suspect the clinicians are using the criteria found in the guidelines for the most part. I think the limitation that many of us recognize lies within the guidelines, that we need more data in several groups of patients. First is the fact that numerous studies have shown that, in fact, patients with an ejection fraction of 30% or less or 35% or less actually account for no more than at most half of the patients that experience a cardiac arrest in our society. So we're missing the boat and the potential utility of defibrillators in probably most of the patients that might benefit from them. On the other hand, we are implanting defibrillators in many patients that are not likely to benefit from them, either because they have a number of comorbidities that increase their mortality risk from non-arrhythmic means, as well as roughly 25% of patients whose ejection fraction is in the guidelines range, that is less than or equal to 35%, but who have no apparent other risk factors for sudden cardiac death. And based on analyses from the MATE-2 trial, from the SCUD-HEF trial, as well as from the multicenter unsustained tachycardia or MUST trial, they are at very low risk for arrhythmic events spontaneously, and by that account are unlikely to benefit from implantable defibrillators. So we need further studies validating multivariable models of risk so that we can bring them into contemporary practice and use these devices in a more rational manner.
And just finally, which variables do you think should be considered in these trials going forward?
There are a number of factors that seem to contribute to risk. Unfortunately, most of them are identifiers of risk for both overall cardiovascular mortality as well as arrhythmic risk. But these include the presence of heart failure. A number of electrocardiographic variables have been shown to contribute, and these include the duration of the QT interval, the duration of the QRS interval, the presence of left ventricular hypertrophy, certain parameters based on measurements of the T wave, such as the peak of the T wave to the end of the T wave. Age is very important contributor to overall mortality. The presence of atrial fibrillation has been shown to correlate with increased risk for total mortality and may also contribute in some cases to risk for arrhythmic death. And finally, in patients in whom none of these risk factors are present but have low ejection fraction, it would be very logical to perform electrophysiologic testing, and the presence of inducible sustained monomorphic ventricular tachycardia has been proven to contribute significantly